Hi, my name's Colleen Campbell, and today I'm going to talk about how to improve success in vascular access using ultrasound. Why should we use ultrasound? It's faster, it's more comfortable for patients, there are less risks of complications, it is the standard of care for most access. And why would you do something blind when you don't have to? Speaking of blind, this is what happens to skiers who are blind, and something similar happens to when we try to put in deep lines blind. So today we're going to talk about a few different veins. We're going to talk about access to the internal jugular vein. We will talk about the subclavian vein access as well as the femoral vein access. Peripherally, we will teach you how to cannulate the cephalic vein as well as the basilic vein and deep brachial veins. Let's start with central venous access, the internal jugular vein, subclavian vein, and femoral vein. Traditionally, the internal jugular landmark method was in between the sternal and clavicular heads of the sternocleidomastoid muscle. We would be at the apex of the carotid triangle and aim for the ipsilateral nipple. Then we started to use ultrasound, and evidence built up in favor of ultrasound versus traditional and landmark techniques. There was less time to initial cannulation, less number of punctures, and less complications. Miller and Roth studied this in Academic Emergency Medicine in 2002. They had 122 patients and found that the mean time to puncture for ultrasound was 115 seconds, versus by the traditional method it was 512 seconds. The number of attempts for ultrasound was significantly less at 1.6, and traditional method was 3.5 on average. There was also lower complication rates, and the traditional landmark complication rate was approximately 14%. These complications included pneumothorax, hemothorax, and arterial puncture. They found carotid artery puncture in 8% of cases. This is in deep contrast to ultrasound-guided complication rate, which the carotid artery puncture rate was only 1.7%. So why is the landmark technique so difficult? Well, Denny's looked at this and found that the IJ vein is anterior and lateral to the carotid artery 92% of the time, and some of this is very dependent on the urgency of the situation. So there's an 85% success rate in elective lines, 76% in urgent lines, and 62% in emergent lines. This diagram shows the variability of the internal jugular vein anatomy. So how do we use ultrasound to cannulate the internal jugular vein? First, we start by covering the transducer with a probe cover, or put gel inside a sterile glove if you're in a pinch. Use a high-frequency linear probe. Hold the probe above the clavicle in transverse orientation, and place the machine facing the head of the bed and match the marker dot to what you see on the screen. We start the same depth as the vessel is deep, away from the middle of the probe, in order to see the vessel being cannulated under the ultrasound screen. So how do we tell which is which? Which is the artery and which is the vein? We can identify the internal jugular best by placing the patient in Trendelenburg to blow up the vein. Turn the head 30 degrees to the opposite side. Have the patient start applying Valsalva pressure and use very minimal probe pressure. If you use Valsalva or exhalation, the size of the IJ will increase by at least 50%. And then next you can compress and see that the vein is easily compressible and thin-walled. The cannulation technique is as follows. We center the probe directly over the vein. Short axis is usually easiest, and use the centimeter markers on the side of the screen to determine the depth of the IJ. Direct the needle directly under the center of the probe, aiming inferiorly. And keep the needle in a perpendicular plane to the long axis of the probe. So this is where we would place our probe to look at the IJ. And this is what we would see. We would see that the vein has respiratory variation as this internal jugular. It's also not quite circular in shape. Here's the carotid artery, and right next to that we see the thyroid gland. Here's an example of what happens when you put pressure on the probe. You can compress the IJ quite easily, whereas the carotid will maintain its shape. Other helpful hints include that the needle may not be visible when you cannulate the vein, but what you will see is a reverberation as the needle enters the vein. I remove the ultrasound machine once the vein has been successfully punctured and the wire is in. Next, we're going to talk about subclavian anatomy, and this is my favorite line. So we see here in this diagram that the subclavian and the IJ form the brachiocephalic trunk and a venous lake per se, especially on the right side. So traditionally, the subclavian could be approached either infraclavicular or supraclavicular. For the infraclavicular method, you start at the lateral middle third of the clavicle, approximately a centimeter down and a centimeter lateral to the angle of the clavicle, and aim for the suprasternal notch. For the supraclavicular approach, you start lateral to the clavicular head of the sternocleidomastoid and aim towards the contralateral nipple. And this is what you get oftentimes, especially if the patient is not in Trendelenburg. And here we see a tension pneumothorax on the left lung of the patient. Ultrasound-guided subclavian vein catheterization has been well described. Supraclavicular is a great line, especially if somebody is very, very dry or hypotensive. How you do this is you place the transducer just above the clavicle, similar to as you would place it for an IJ. You can even find the IJ and march down the IJ with the probe and then angle into the chest to see the subclavian. The skin puncture is going to be underneath the long axis of the probe, 1 centimeter lateral to the sternal notch and 1 centimeter superior to the clavicle. You continue to aim into the chest or caudally towards the visualized subclavian vein, and the vein will be anterior to the artery. So the red arrow depicts the angle that your needle will take underneath the probe. Again, we can follow the IJ inferior into the chest and then place the needle under the long axis of the probe. And what we're looking for is this venous lake made up between the IJ and the subclavian vein, which form the brachiocephalic trunk. The infraclavicular ultrasound guidance to subclavian vein is also a handy approach and one I've used frequently. You place the transducer in long axis, just inferior to the lateral aspect of the clavicle. And you place it at the lateral most aspect of the clavicle. And then Move the probe 2 centimeters medial, and then you will do your skin puncture, going from lateral to medial. You will aim directly for the visualized vein and not attempt to get underneath the clavicle in this approach. This is how you would hold your probe. And what you would first see at the lateralmost aspect of the clavicle is actually the axillary vein and artery. So here we see that the axillary artery is superior to the axillary vein. Then we move the probe 2 centimeters medial, and that's when the axillary artery and vein becomes subclavian. This has been studied by Depp, and what they did was they did cannulation 2 centimeters medial to the most lateral inferior aspect of the clavicle. They took new interns or PGY2s who were rotating in the ICU, and what they found was a remarkable success rate for this approach, 92% versus traditional of 44%. The complication rate was 4% for ultrasound versus 41% for the traditional approach, and less kits were used in the ultrasound approach as well. And this is an example of how you would set up for it. You could either have another operator holding the probe, or you could hold the probe with one hand and cannulate with the other hand. And this is what you would see on the screen as you did this approach. What we would see is subclavian vein right here, subclavian artery here. Our marker dot is up, so this is head to foot. This right here is pleural line, and you can see how close it is to the vein, and you can imagine doing this procedure blindly. As scary as it may seem, doing it with ultrasound, it's more scary to do it blind, as there's not a big gap between the subclavian vein and the pleural line here. This is an example of me supervising a resident. They're aiming for the artery. I redirect them to the vein very quickly and loudly, I might add. And here they start aiming for the vein instead of the artery. This is an example of cannulation, and you have to watch this closely. You see that we are directly above the vein here, and you see that flash of light is the vein is cannulated. That's a reverberation right there, and that means that the vein was cannulated successfully. You can also notice that the posterior wall of the vein has not moved at all, and you know that you did not puncture the pleura in this way. Now what you see here is a different story. You see the artery here and the vein here with respiratory variation, and here's pleural line. And we notice that this pleural line is not moving much. And this was why we chose this site to do a left subclavian vein cannulation, as the patient actually already had a pneumothorax, and so we figured there would be no harm done in doing this left subclavian vein in a new operator. Now, using the ultrasound, the other nice thing is we can immediately check, oops, did I give the patient a pneumothorax or not? And what we notice here is this is the pleural line. So this is lung, and these are A lines, and B lines are created as the parietal and visceral pleura slide upon one another while breathing takes place. And so as long as they're sliding, that's a very good sign that there's no pneumothorax. This is what a pneumothorax would look like. Again, this is rib shadow, rib shadow. This is also called the bat sign. This is the pleural line, and we see no sliding of this pleura at all, and that is what a pneumothorax looks like. So we actually studied this in the ER and had a lot of patients in each group, and found, even though I had trained in surgery and done a ton of blind subclavians that the overall success rate for ultrasound was 79% versus the landmark technique was only 59%. Success rate on first pass was a little bit higher in the landmark method. It was 36% if you could get it easily versus ultrasound was 25%. For residents, the success rate for ultrasound was 81% and versus 58% in the landmark method. There was not a big difference between those success rates between residents and attendings. It did take a little bit more time to do the puncture under ultrasound guidance, and the two complications we saw were patients with pacemakers. The IJ actually, the wire actually fed up into the IJ. So that was the two complications we had in this group. And both of those patients had pacemakers, so that may have been why this occurred. Now let's talk about traditional femoral venous access. Traditionally, we find the femoral artery pulse, and we cannulate the vein just medial to the pulse that we feel. And the vein actually may be posterior to the artery, so we weren't always successful. So femoral vein cannulation has been studied during CPR up at Highland, and this was published in the Annals of Emergency Medicine in March of 1997. They had 20 patients with bilateral femoral venous access. The control side was the traditional technique, and what they found was success rates of 90% using ultrasound versus only 65% success rate using the traditional methods. Cannulation attempts using ultrasound were an average of 2.3 versus traditional were 5. Arterial punctures were 0% in the ultrasound group versus 20% in the traditional group. So much more successful using ultrasound to cannulate the femoral vein in an emergency situation. And this is, again, what we would see. We could compress and see what is vein and what is artery. And the vein will be easily compressible. Next, let's talk about peripheral venous access. This will include external jugular veins, deep brachial veins, and basilic or cephalic veins. So when we're trying to get a tough IV stick, oftentimes there's no veins available that we can find on our own, and that's when we bring in the ultrasound. And we can cannulate the cephalic vein, the basilic vein, or the deep brachial veins. This has also been studied up at Highland in 99, and they did deep brachial vein and basilic vein cannulation. They had 101 patients, and they used 2-inch catheters, so longer than the average catheter. They had a 91% success rate using ultrasound-guided cannulation, and 8% of those fell out. They had 1% brachial artery puncture and 1% paresthesias. This is in deep contrast to traditional deep brachial vein puncture, which showed 8% arterial puncture and 18% paresthesias. And what you do for this technique is you really set the probe to 2 centimeters or the least depth possible. The next thing you do is you hold the probe at the neck of the probe to apply minimum pressure on the skin as you place the probe over the vessel. Here you see artery, here you see vein and vein. This is where you place the probe on the arm. Again, you're going to use minimal pressure, and you're actually going to hold the probe down further towards the neck of it. This probe is being held this way just so you can get a good picture of where it should be. So you're going to use the linear probe, You're going to get all of your supplies ready and get some long catheters available. You can also use arterial line catheters as a backup tool. And what you'll see in the antecubital anatomy is you'll see the humerus deep, and you'll see the typical bone shadow. And then you will see 2 deep brachial veins and a deep brachial artery. You'll use a long catheter and start at a very superficial angle. You'll start 5 millimeters away from the desired puncture site, and you're going to use the ultrasound screen as your eyes. So as soon as you puncture the skin, you're going to be looking at the ultrasound screen. I oftentimes start this procedure by pressing directly over the vein to make sure I'm going to be puncturing the skin at exactly the right spot. This is a single operator procedure. It's usually easier to redirect this way. Once you get flash, you're going to advance the whole unit 2 millimeters further to get the plastic part of the catheter into the vein, and then you can just swizzle out the introducer wire. And again, this is the anatomy. This is the deep brachial artery, and then the paired veins here. And you can choose either one. I would press with my finger above to make sure I was in the right spot, and we'll see our needle coming in short axis. When I first get flash, I just sit there for a moment, and then I will thread the catheter in slightly further. This is what a thrombus in the deep brachial vein would look like. You will see the vein will be filled with echogenic material. And here you see an actual puncture of a deep brachial vein right over here. You see that the vein compresses, and then they'll get the cannula in. This is me trying to see if I was in the right spot. And what I did is I shot in some saline through my catheter that was under the skin, and I found that I had a lot of extravasation here, and I knew that in fact I was not in the right spot. So this is infiltration. You can also use the same technique to cannulate the radial artery, and the data is pretty good for that. This was published in Academic Emergency Medicine in 2006 by Shiver. It was a prospective comparison of traditional versus ultrasound technique, and they found that there was less time to placement using ultrasound, 107 seconds versus 314. The attempts were about half, and there was less sites attempted. And for the radial artery, we'll just see one little artery there, and oftentimes just trying to see the artery will compress the veins. In conclusion, I'd like to encourage you to use ultrasound whenever you get a chance. Ultrasound-guided access is simple, it's easily learned. Ultrasound is time effective and much more successful. You also have a tool right there to confirm your placement and confirm that there is no pneumothorax. It can oftentimes turn around those line flail days when you just can't get it in the right place. And remember, you have to just practice. The more you do this, the better you will be. Thank you for your time, and I hope you don't have any questions.